We use the word disengaged a lot in provider performance. So when a provider isn't responding, they are disengaged. When performance isn't moving, they are disengaged. When the field team has visited that practice 3 times and still can't get traction, disengaged. And I get it, it's a convenient label. But I've started to think that word is doing too much work for us, because provider disengagement isn't a diagnosis. It is a symptom. And if we don't understand what is actually causing it, more outreach may be doing exactly the wrong prescription. So think about what is underneath that word. A provider who doesn't trust your data may not respond. A provider who is frustrated with another part, with another unit, with another sector, with another department of the health plan may not respond. A provider who doesn't have the right authority to do what you're asking them to do may not respond. A practice that is already fielding competing requests from multiple health plans may not respond. And from the outside, every one of those situations looks exactly the same. There is no movement, no response, but they are very different problems and they require very different interventions. So today, I don't want to talk about how to increase outreach. I want to talk about how to diagnose the problem before we decide what to do next. Well, that is what we're going to be diving into today. Let's get into it. So when a provider performance isn't moving, the first instinct is usually the same. Send another report, make another call, you schedule another visit, escalate to the practice. And I understand that instinct because it feels like it's an action, but activity isn't diagnosis. If I don't understand why a practice isn't responding, how do you expect me? How do I know another touch is the right intervention? Maybe it is, maybe it isn't. But I found it useful to think about provider disengagement through 4 diagnostic questions. And the first question is, does the provider believe this matters? The second question is, what relationship are we walking into? The third question is, can the person we engage in actually act? And the last question is, when they engage with us, do they see a visible return from that effort? You see, those are 4 different questions that can completely change what happens next. So let me start here because I think it is easy to underestimate. When we send a gap report, we know why it matters. We know why. HEDIS, STARS, member outreach, risk adjustment, from contract performance, right? But from the provider lens, they may be looking at that information differently. And there are a few different things that can happen. The first is simple. They may not trust the data. Maybe they have responded to previous gap list only to realize that the care had already occurred. Maybe there was an attribution issue. Maybe they submitted information and the gap continued to appear. So whatever the reason, repeated experiences like that can change how seriously the next request is taken. And that is not something we can fix by simply increasing the frequency of the report. We have to fix the credibility problem. The second issue has to do with relevance. Sometimes the plan is asking for evidence needed to accurately reflect the care that occurred. But the physician may see the same request as an administrative request for something the practice already knows clinically. We are speaking HEDIS, but the practice, the provider, are thinking about the patient sitting in front of them. So we have to connect those worlds. We have to connect the dots. And instead of saying, here are your open measures, open gaps, you need to help the practice to understand what the opportunity means clinically, what the data is showing, and what specifically needs to happen next. And then the third issue is sometimes disengagement becomes genuinely clinical. So the physician may disagree with how we are framing the opportunity or what we're asking them to do. And that is where the field rep shouldn't be expected to carry the conversation alone. Bring in the right clinical voice. The field team's job isn't to be everything to everyone. It is to understand the problem very well enough to bring the right perspective, the right person into the conversation. It's the same symptom, provider isn't responding, but very different causes, very different interventions. Now, here is something quality teams can easily miss. You see, inside a health plan, quality may sit separately from utilization management, may sit separately from claims, may sit separately from risk adjustment, may sit separately from network management, may sit separately from provider engagement or provider relationship. Right? Those are distinct functions internally, but the provider doesn't experience our organization, our health plan, or our organizational chart. They experience one health plan. So we may have 4 departments with 4 legitimate reasons for contacting that practice, but the practice experiences 4 interruptions from the same health plan. And that is an important difference. So when a field rep walks into a practice to discuss quality performance, they may be walking into a relationship that already has a history. Maybe there's an unresolved payment issue. Maybe there was a difficult authorization experience. Maybe another team from the same health plan contacted them last week about something completely different. You see, the field rep may know nothing about that context, about that information, but the practice, on the other hand, does. And that is why before we label an important provider as disengaged, I think we need to understand what relationship are we walking into actually. Not because quality can fix every claims issue or authorization dispute. It can't. We know that. But the context changes how we engage with them. Sometimes it can change who should engage. And sometimes another issue needs attention before even the quality conversation can really land. You see, the field teams are often the first people to recognize this. And that is a much more strategic role than simply delivering another gap report. Now, this one shows up than we realize. Sometimes we engage in the right organization, the right practice, and completely the wrong person. If the issue is operational, scheduling, workflow, documentation processes, the practice manager may be the exactly right person. If the disagreement is clinical, we may need clinical to clinical engagement. If the issue is contractual, we may need someone from network management or contracting involved. In a larger medical group and health systems, decision making can become even more complicated. Some decisions happen at the practice level. Others may sit within population health, within quality leadership, within contracting, within system leadership. So the job isn't simply to move every conversation upstream. The job is to try to understand, where does this decision actually live? I've started thinking about this as a decision rights problem. And that is very different from an engagement problem. You can have a great conversation with someone who has absolutely no authority to do what you're asking them to do. What happens? Nothing changes. And then the plan concludes the provider isn't engaged. Maybe that is not a problem. Maybe it's our targeting that was wrong. Maybe the better question isn't, did we contact the provider? That is an activity measure. The better question should be, did we engage the person who can actually change the outcome of the practice with that provider? You see, that is a different measure of effectiveness. Now, this is one of the simplest things that we usually get wrong, and the effect compounds over time. So the provider responds to a request. They updated the documentation. Their staff sends the information we requested. They change a workflow, and then nothing. There is no feedback. So the provider is left in limbo, trying to understand, did the gap close? Was information accepted? Did anything change? They don't know. They don't have the right perspective. So over time, the practice can learn something from that experience, and they form the the notion that responding to this helpline creates work, but I cannot see what happens afterwards. That is not a great loop for sustaining engagement. The model should be simple: request or engage, action, and confirmation. You asked me to do something, I did it. You told me what happened. Now, closing that feedback loop isn't as always simple as it sounds. Different data sources move at different speeds. Claims have different processing timelines. Supplemental evidence may need to be reviewed. And sometimes what the provider believes should close the gap doesn't satisfy the applicable measure requirements. We don't have to pretend every action can be reflected immediately, but we shouldn't leave the provider wondering whether their effort disappeared into a black box. If we received it, acknowledge it. If it worked, let them know. If it didn't, explain why. That is the feedback loop I'm talking about. And when practices are balancing competing demands from multiple payers and programs, that experience matters, because our goal shouldn't be to become the health plan that contacts them the most. It should be the health plan that is the easiest to work with. You see, make the ask clear. Make the information credible. Reduce the unnecessary steps. Coordinate internally. And when the provider acts, close the loop. Now, this is where I think provider field teams have an opportunity that the organization don't always fully use. The dashboard can tell leadership that a provider isn't moving. The field team can often tell leadership why. Maybe the practice doesn't have the right report. Maybe they are frustrated about something else. Maybe we are talking to someone who cannot make the decision. Maybe multiple health programs are contacting them independently. Maybe they acted months ago and still don't know what happened afterwards. You see, those aren't just anecdotes. They are operational intelligence. And if the same issue starts showing up across multiple practices, that is no longer just a provider relations problem. That is a signal about our operating model. Leadership needs to hear about it. The field team's most valuable role isn't simply executing outreach. Rather, it is helping the organization, helping the health plan to understand what is actually happening at the practice level, and then feeding that intelligence back into how we operate. So the next time a provider isn't responding, I would resist the instinct to immediately increase outreach. Diagnose first. Does the provider believe this matter? And if not, is the problem data? Is it related to relevance or the conversation itself? What relationship are we walking into? Is there something else happening between the practice and the health plan that is affecting this conversation? Are we engaging someone who can actually make that change? Or are we having a conversation, a great conversation with someone who has no authority to act? And when the provider does engage, do they see anything afterwards? You see, I keep coming back to one idea. You cannot expect a 5-star outcome from a 1-star provider experience. We spend a lot of time measuring provider performance, but provider performance is only one side of the relationship. We should also understand how we are performing as a health plan partner. You know, how credible is our data? How coordinated is our outreach? How easy are we to work with? And when providers act, do we close the loop? Because provider disengagement isn't a diagnosis, as I stated earlier. It is a signal that tells us where to start looking. Well, I am Peter Saar. Thank you for your time. Thank you for listening or watching. I will see you in the next episode.